Okay, so this CT scan is of a 21-year-old female, and she has history of right-sided abdominal pain for almost 2 weeks, and we don't have any prior for this patient. So on this, let me. So initially, this patient underwent contrast in NCT in the ED, but without oral contrast, and this shows a big, well-defined, probably fluid attenuating lesion somewhere on the right side of the abdomen. So the location would be the key to the diagnosis, I suppose. And I can show you, soon after that, we did another CT scan with oral contrast. So this is with, no, okay, this one is with oral contrast, and the oral contrast did not go into this lesion. So any guess or any other finding that you see that might be pertinent to the diagnosis?
Did you see a separate appendix?
Oh yeah, that's a very good thought. Let's see, I think we see an appendix here. I think it is better seen on the other image. Yeah, I think we see a little bit of appendix here. I think it's better seen on this one. Let's go down. Yeah, it's somewhere here. So this thing was separate from the appendix. Even in this one, in this image, sagittal, we can see a separate blind ending tubular structure arising from the cecum, and this thing is separate from this lesion, at least up to here. So this is not arising from the appendix.
Sorry, can you scroll up the axial again? It's there was a separate gallbladder, right?
Let's see. Yes, we see a gallbladder.
Oh yes. Okay.
Separate. Yeah.
I'm almost wondering if it's like a duplication cyst.
Why do you think that?
It looks like it's like submucosal to some bowel loop there.
Yeah, I think you're absolutely spot on. So here in this image, we can see claw sign that we frequently talk in the kidney and liver, but even in the bowel, we can see in this particular image, it has a claw sign with the adjacent bowel loop, and this bowel loop is the ascending colon area, and this is the lumen of the ascending colon. And if we see on the, even on this image, we can see there is some debris on the dependent aspect on axial as well as the sagittal, and little bit of fluid and stranding in the paracolic gutter area. So they resected it and they found it to be simple benign duplication cyst from the ascending colon. And there was no malignant cell on analysis of the cytology. So yeah, big 18 centimeter.
Wow, it's huge
cyst.
and it's rare.
Yeah. That's one.
Sorry, I came in late. How old was that patient?
21 year old.
Okay, thanks.
Yep, sure. And this is a scrotal ultrasound of a 41-year male, and this guy came with left scrotal pain for a few hours duration. These two images are done 1 day prior, and this two images are done on the following day. So when the patient came at first, they did scrotal ultrasound, and we can see the left testicle a little bit enlarged and a little bit more vascular compared to the right side. There is normal flow on the right side, and if we look at the left side, the flow is it's okay, I would say, a little bit maybe increased or not, and the epididymis is slightly enlarged, 7 millimeter, and very hypervascular. So initially they thought maybe it's Epididymo-orchitis, and the patient was given some antibiotics, and then patient was sent home. 24 hours later, the patient came. Before going to the next ultrasound, what do you think of this case? Was the report that said Epididymo-orchitis okay, or do we need to raise concern for something else?
I would have thought epididymo-orchitis. I guess another possibility is torsion, detorsion.
Yeah, that's the exact thing that I want to discuss and also get your insights, because as a resident, I'm not that very comfortable in distinguishing partial torsion or torsion detorsion versus early epididymo-orchitis. So yeah, let's go to the other current ultrasound, and then we can discuss how to differentiate them. So 24 hours when the patient came, now we see the right and left testicle again. In the right side, we see more flow now compared to the left side, though the left side is still symptomatic and the right side is not. This is the right testicle, and the right testicle again shows normal flow. Let's see that on the left side, now we see the vascularity has decreased, and we can see the arterial flow is high resistance with resistive index of 1. There is some flow below the baseline. And now because of this appearance, like decreased blood supply, and with this spectral flow, the report now read as concern for torsion. So one day prior, they say Epididymo-orchitis, and now the next day they say torsion. So do you agree with the reports or the impression, or was it early torsion or partial torsion detorsion, later followed by complete torsion, or initially it was early epididymo-orchitis and now it is like so severe, very severe orchitis? Because the management would be different, at least initially, right? Because torsion would go for surgery and the epididymo-orchitis go for medical management. So how do we differentiate, or do we always raise suspicion of torsion when we think of epididymo-orchitis, or the other way around?
I think this is tricky, but maybe the history would be different. Like the epididymo-orchitis would be more of a slow increase in the pain, and like, maybe fevers, but kind of like a slow progressive pain, whereas the torsion, detorsion would be more sudden, just clinically. But otherwise, I think it was appropriate. I would have called the first one probably concerning for epididymo-orchitis and the second one concerning for torsion.
Yeah, so it's a bit tricky. It's, like, since I'm just learning, I just wanted to get your opinion. The other things I could think of is, one is definitely the age, right? Because probably torsion is more common in the adolescent, and when the patient is now sexually active and middle-aged, or like elderly, they might get epididymo-orchitis. And since epididymo-orchitis is more common compared to torsion, so common things being more common, I would think also of epididymo-orchitis, but only based on imaging, because many times we do not have the clinical data, and we can't completely rely on history of the provided by the ED, and we don't go and see the patient ourselves. So I'm just like confused about this basic but yet though very difficult question.
I mean, I would have to say that when I trained, we personally scanned the majority of patients that came, and some of them were coming out of the ED. And when I was on call, I had to do my own ultrasounds in the ED. Many of us have gotten away from that, with the growth of MRI and CT keeping us busy. A lot of departments have moved to, sonographers only doing the exams and seeing in person the minority of cases. And I think in cases like this, that makes a difference, because you can't be as good a radiologist if you're not knowing what exactly is going on with the patient, and maybe, talking to them yourself.
Yeah, thank you, Doc. Just one another question. Do you think the torsion, when there is a complete torsion, we would still be seeing flow in the epididymis? I remember from basic, from college days, but I'm not sure if I am correct or not. So the spine, not the spermatic cord has 3 arterial blood supply, something testicular, cremasteric, and I don't know, arterial vas difference or something. So in testicular torsion, maybe only the testicular artery is compromised, but the others are not, or is this false statement?
I'm not sure if I know the answer to that one. Not with confidence anyway, and I'm not. I don't dare put out any black pearls.
Yeah, I don't know either.
Yeah. So this guy, I looked at the chart, and this guy UA was positive for bacteria and the culture group Klebsiella pneumoniae. And when they when they did surgery, they found very necrotic left testicle, but there was no evidence of torsion. So this was a case of severe Epididymo-orchitis with severe orchitis leading to testicular necrosis.
Wow.
Yeah, thank you.
Cool. Christine, do you want to go?
Sure. All right, so let me share my screen. Actually, one second. Okay, great. So this is a postmenopausal woman coming in with vaginal bleeding, and she has a history of fibroids. And on the left side here is a ultrasound from 2019, and then more recently, she had an ultrasound on the right here. So I wanted to show this case because oftentimes we get overwhelmed by fibroid follow-up, and in this case, we had actually initially missed a finding on the recent ultrasound. So if I slow this down, I think that the endometrium can sometimes be very, very difficult to follow, especially in the presence of so many fibroids. But in this case, you can see that, the endometrium is actually this echogenic part right here. It's quite thickened, especially in the presence of postmenopausal bleeding, and there's some cystic areas within it. So this ended up getting biopsied and was carcinosarcoma of the uterus. So I just wanted to show this case because, we had kind of overlooked the endometrium at first. And I guess, especially if somebody is coming with vaginal bleeding, it's always important to try to look at the endometrium carefully, so as not to miss the cancer. So she actually and then had a CT for staging, and so she had no meds, which is good. And as you can see here, the finding is much easier to see actually on CT, where the endometrial canal is very distended with, hyperdense material within. It's probably a combination of the tumor and maybe some blood products. And you can see how all these fibroids could potentially obscure the endometrium on ultrasound. So that's one. And then my other case is this one here. So this is a patient who came in with abdominal pain, and right off the bat in the liver, there are these, there's some clearly cystic lesions, but then there's also these more ominous looking hypodense lesions in the liver. And as you stroke down, there's a lot of, what looks like peritoneal metastases. So we were pretty lucky in this case because I feel like we don't always see mass in the small bowel, but in this case, we could identify the primary, which is this loop of jejunum here, where there's a pretty ugly looking mass. And I think it's just very fortuitous that the patient drank oral contrast and was the jejunum was nicely distended, allowing us to look at the mass pretty well. And that's all.
Those are great cases. That's sad, and it kind of shows you how aggressive small bowel adenocarcinoma is. Like
Yeah.
that small tumor already has all those peritoneal mets.
Right. It's pretty sad case. All right, so I'm gonna stop sharing.
Okay, I have a few. Okay, this is my first one, and I want you guys to, I can't see the chat, so I want you guys to speak up. This was a young patient who had abdominal pain. I do have an MRI too, I can show you, but what are your thoughts just based on this first scroll through? This is the only phase I have for the CT.
At first, I thought I was looking at some abnormal liver, but I think this is maybe some sort of extrahepatic mass. There's too much soft tissue everywhere.
Yeah, so all of this is masses, and you can see actually that there's a lot of hypervascularity, neovascularity. And just while I'm on the CT, I want to show one more thing, which is there are some calcifications in it, which is a little bit of a clue. And actually it is from the liver. So here on the non-con, you can see like the left lobe of the liver is where the mass kind of starts. And it's involving the entire left lobe and then kind of like growing out of the liver. And then I'll show you on MRI. So this was the T2 of the MRI. So you can see like the whole left lobe is taken over by these masses. And it's kind of growing out. This was the pre-contrast.
Aarti, did you say how old the patient was?
They're around 20. This is the arterial phase. And you can see there's also peritoneal nodules. Here. And then this is the delayed phase. Someone read the chat because I can't see it.
Fibrolamellar versus angiosarcoma was in there.
Good, excellent. So this actually did turn out to be a fibrolamellar HCC. And actually on the CT, we can better see that there's even pelvic metastatic deposits and like a lot of little peritoneal deposits here. So unfortunately, this is metastatic fibrolamellar with peritoneal disease. So I just had a couple of teaching points about fibrolamellar. It tends to be in young patients. So HCC is much less common in patients under the age of 40, whereas fibrolamellar is mostly in patients under the age of 40. It has a male and female equal predominance, which actually I thought it was in younger females, but turns out it's equal in male and females. They tend to not have any underlying liver disease. They don't know why these patients get it. They tend to be very large masses with lobulated borders, central scar. So people sometimes will talk about, fibrolamellar versus FNH, but these are much, much more heterogeneous and aggressive looking than FNHs. They're hypervascular, and I think like 40% will have calcifications. So that was the clue I was trying to show on the non-con CT. The AFP will not be elevated, and it won't stain for the same things as HCC. So even though it's called HCC, it's a very different etiology and pathway. Very high rate of recurrence in metastatic disease. If it's localized, they can do surgery, and now there are some immunotherapy trials. So this patient is now on immunotherapy trial, but high rate of metastasis and recurrence.
think that might be the biggest fibrolamellar that I've seen.
Yeah, I know, it's crazy. We were trying to figure out like, why did this person get it? But I was looking up some papers and really they have no idea why people get it. So, okay, this one is my second case. This patient was undergoing a liver transplant donor workup. They were going to try to donate the left lobe of their liver to an infant. So we do like a multiphasic CT to look at their vascular anatomy to see if they have any portal venous or hepatic arterial anomalies. And do you guys see any pertinent findings here?
There's some big collaterals.
Yeah, exactly. So there's this huge vessel here, which is actually the gastroepiploic vein. And there's also gastric varices here. So can anyone figure out in this patient what is causing this? There's a clue right here. So this patient had a distal pancreatectomy for a benign lesion. They were a younger patient, but they had a benign cyst, resected somewhere else. We don't have the path. In the process of that, they did not remove the spleen, which is more along the lines of a benign distal pancreatectomy. However, they did remove the splenic vein. And so this is the sequela of splenic vein removal, which is basically called left-sided portal hypertension, where your spleen is now draining through the gastric veins as well as the gastroepiploic vein. So I just have one slide about this. So I never really understood what left-sided portal hypertension was or what it meant, but basically it's when you have isolated either thrombosis or resection of the splenic vein that causes the left side of the portal venous kind of system, mostly the splenic system, to have this portal hypertension, and then it'll drain through the short gastrics into the gastric wall, and then also into the gastroepiploic vein. So this can actually cause pretty significant GI bleeding, which is usually when they become clinically apparent. So in this case, it was caused by surgical resection of that splenic vein. But anyway, and because of all these collaterals, this left-sided portal hypertension, the patient was not a surgical candidate for a liver donor.
We don't have any surgeons here, but I'm wondering if, I mean, I guess if this happened when the patient was young, the idea was to leave the spleen in because of the immune consequences, perhaps?
Yes, I think so. So generally, if they're doing a distal pancreatectomy for a malignant process, they will remove the splenic artery and vein and therefore the spleen. But if they can if they can leave the splenic artery, which they have here, they can, spare the spleen. So I guess like, your question is like, should they have taken the spleen out so we didn't get these big collaterals and just deal with that? Yeah. That's a good thought.
My concept of it is you'd have to, if you're going to leave the spleen fed by an artery and you're going to take away the venous outflow, this is going to happen.
Yeah. That's a really good thought.
But maybe the idea is not to do the splenectomy if the patient was so young that as your immune system forms, I think there's some value in having the spleen on board. Now we don't have a hematologist, a pediatric hematologist here, somebody to verify that one, but that's my concept of it anyway.
Yeah, that's a really, really good point. Okay, this is my next case. You can see there's a process going on in the pancreas. You guys all are going to get this. So, this is a pretty locally advanced adenocarcinoma. So hypoenhancing mass causing pancreatic ductal obstruction. The unique part about this case is that there is extensive involvement of the celiac axis. So is this resectable, unresectable? You have to speak up.
Unresectable.
Okay, I like it that you spoke up, but that's not the answer. So the clue here is that there is a replaced right hepatic artery arising from the SMA. And there is a GDA that is robust and intact. So what surgery can the surgeon do? Anyone? So they can do an Appleby procedure, which is basically a distal pancreatectomy with resection of the celiac axis. But the only way they can do that is if you have an intact GDA, and even better if you have a replaced hepatic artery arising from the SMA. So the problem with resecting the celiac axis is that you need your hepatic artery. You don't need your splenic artery, you don't need your gastric artery, but you do need your hepatic. But if you have an intact GDA, the SMA can actually feed the GDA retrograde through the pancreatico-duodenal arteries, and it'll fill the GDA retrograde, and then that'll fill the hepatic artery. In this case, that retrograde flow is going to feed the left hepatic artery, and then the right hepatic artery is spared because it's arising from the SMA and it's separate from the tumor. So especially if you have this replaced right hepatic artery, you can do this Appleby procedure and resect the proximal aspect of the hepatic artery. So I'll just show you what it looks like. So this is, it's called an Appleby procedure. I think it was made by Appleby in the 50s. If the tumor is involved in the celiac axis, they can resect this and the proximal portion of the hepatic artery, and then they ligate it here, and the inferior pancreatico-duodenal retrograde feeds the gastroduodenal, and then that feeds the hepatic artery. It's not common, you know, it's a complicated procedure, but it is something that they can do if they have this intact and robust GDA.
Aarti, I have a question.
Mm-hmm.
Is this done in patients who only have the replaced anatomy?
No. So it's this patient is lucky. They have this really nice replaced right hepatic artery, but they can do it if you just have, so for example, this diagram, it doesn't have a replaced artery. It's just it's the arcade that everybody has around their pancreas, but you have to have a nice arcade here, including a big GDA. And this tumor cannot go all the way to the origin of the GDA. So there needs to be enough space that they can safely cut through the hepatic artery here and maintain this GDA to hepatic artery.
Nice. So this is like twice lucky because they have.
Yes. Yeah.
Yeah.
Wow. I think maybe 10% of people have a replaced right, but yeah, this is exactly, it's super lucky in this case that he had that. And then the left hepatic artery will be fed retrograde like this.
Aarti, do you know if it would be possible if it was the other way around, if it was the proximal SMA that was involved and they still had a GDA?
Huh. I don't think that that's possible, because I don't think, like, for example, when the SMA is involved, they don't say like, oh, we can just resect that. And then you're basically saying the entire SMA. So all of the GI tract blood would be fed through the GDA. And I haven't seen that happen.
Yeah, it may be too much.
Yeah. When the SMA is involved, I mean, that's usually when it's unresectable. And they say, like, for example, they can do grafts on the portal vein or the SMV, but they really don't like doing grafts on the artery because most of the time those grafts don't work well. And also they just like will have tumor recurrence around them, because if the tumor is encasing that artery, they just really like, it's involving all the vein around it, or all the nerves around it as well. Yeah.
Great, thanks.
Mm-hmm. Okay, this one is, okay, so there's a couple of clues. So the lung bases are a little bit of a clue here. And the esophagus is kind of patulous here. The bowel is dilated, but maintains its folds. lots of dilated bowel.
Is this hidebound?
Yes, exactly. And then do you see any other finding here?
Pneumatosis?
Yes. So here we've got pneumatosis of the small bowel. You can see it's non-dependent ringing here. And then this is hidebound bowel. So what is the diagnosis?
Scleroderma.
Yes, exactly. So this is scleroderma. So this is like the hidebound bowel. It's you get dilated bowel, but you maintain the folds. And then they also get patulousness of their esophagus because of the connective collagen deposition in the wall of the esophagus. So it becomes patulous. And they also have a little bit of fibrosis at their lung bases. So this is scleroderma. And the question is, are you concerned about this pneumatosis? There's also pneumoperitoneum.
Yeah.
Is this a normal finding? Is it a common finding? Is it abnormal?
I'm not as concerned as I used to be about most pneumatosis. And I
Yeah.
probably would be looking up to see if this happens in scleroderma. And it probably
Exactly. So that's exactly what we did.
Probably on the list of things that, but so-called benign pneumatosis is associated with.
Exactly. So that's what we did. We Googled scleroderma pneumatosis, and turns out it is actually not uncommon. So I have like one little slide about scleroderma, but and it tends to be benign. So in general, pneumatosis of the colon tends more to be benign. Of the small bowel, we tend to be concerned about ischemia. But in patients with scleroderma, their GI manifestations are basically because the muscularis is replaced by collagen. This leads to gastroparesis, also the small bowel dilation, bacterial overgrowth, constipation. And pneumatosis is actually not uncommon. There was a report from Japan of like 39 patients. And I think these are all case reports. They did a series of, they looked at a series of case reports, and I think 70% of them had pneumatosis. So at least when people are writing case reports about them, it's common, and the patients do well with just conservative therapy. And then these are the theories for why these patients get pneumatosis. So kind of like the luminal distension causing increased luminal pressure and translocation of the air, bacterial fermentation from that overgrowth, also causing increased gas. And then another big one is long-term steroid therapy, which atrophies the mucosa and leads to breakdown. So several reasons why these patients could have pneumatosis. It tends to be benign. They have to, put together with the clinical picture, but this patient actually has had pneumatosis kind of coming and going. And then just one more quick case. This one patient had right upper quadrant pain. What do you guys think about the gallbladder?
Looks like complex coli.
Yeah, and what do you mean complex?
Like probably perfed, contained and perfed.
Yeah. So that's exactly what we were concerned about. It like I was also concerned about, like, is it gangrenous? Because like, is the wall falling apart here? Is it contained perforation? There's obviously inflammation around it. We also contemplated, like, could this be xanthogranulomatous cholecystitis, where you can get like cystic spaces in the wall, but the wall itself wasn't very thickened. So I was leaning away from that. They ended up going and doing a laparoscopic exploration, and this was there was pus coming out of the gallbladder. So this was, I didn't know this term actually, was suppurative cholecystitis, which is when it's filled with pus or purulent material. I don't think we could tell that here. Like, we can't tell the difference between gangrenous, perforated, and actually filled with pus. But they ended up putting in a percutaneous cholecystostomy tube, and the patient's doing better. So good. That's the end of mine.